So I call this liver elastography for non-sonographers. So we're going to start at the very beginning so we can sort of understand what's going on here in the body with sound waves. So sound is a mechanical wave that travels in a straight line. You sort of see right here. Sound has to have something to go through it. It can't travel in a vacuum. And the way it travels is it causes the particles that it's going through to sort of oscillate back and forth. So we have areas of high pressure and areas of low pressure, which are in a cycle. So we have our little sine wave down here with areas of high pressure and low pressure. And it's this way that of these compressions and rarefactions of the medium that takes the sound from the source to the listener. So there's different categories of sound. We're going to be in this category here, 20 hertz to 20,000 hertz. And of course, we all know what 20,000 hertz is ultrasound, and things like bats and whales and all kinds of creatures use ultrasound to communicate and locate prey. And then we got the infrasound here below 20 hertz. This is usually when we feel like vibrations, like a real low note when I say an organ or something, and you don't really hear it, you feel it. So there's really low frequencies. And again, animals use that as a form of communication. So one thing that's going to be important is the propagation speed of the sound wave, also called the velocity. And it's determined by two properties of the medium. One is density, and the other is stiffness. So density is how close all the molecules are together. And stiffness is how well the medium resists compression. So bone is stiffer than liver tissue. As the stiffness increases, the propagation speed increases. So if we take a look here at some values, so fat, 1460, average value of our soft tissue, 1540, which we use a lot in ultrasound. Specifically livers, 1570. But you can see here, as the liver becomes more stiff and more cirrhotic, these values start to go up. So this is how we're able to take that velocity and equate it to a stiffness value because of the property of the sound waves go faster as the material gets stiffer.
Okay.
And the second thing we want to understand is attenuation. So attenuation is the sound being losing energy as it travels through the medium. Like right now, as I'm talking, my voice is diminishing in volume, and so that my wife downstairs can't hear this talk. So it can only travel so far. The major source in ultrasound of attenuation is absorption. So the material, the liver, absorbs part of the sound beam energy to get those molecules to start vibrating. And then there's other things that make up the image: reflection, refraction, and scattering. So the further the sound beam travels, the weaker it becomes. So that's important to understand what's going on, to help understand, what these values, where they're coming from, what's affecting them. The stiffness and the attenuative properties of the liver is what's going to be helpful in us determining the degree of disease process in that liver. So let's take a look at causes of chronic liver disease: alcoholism, hepatitis B and C, fatty liver, non-alcoholic steatohepatitis or NASH, which is on the rise, and then non-alcoholic fatty liver disease. So what happens in this case is the normal liver tissue becomes fibrotic. Of course, fibrosis is stiffer than the normal tissue. As this fibrosis increases, the liver loses a lot of its function, which can lead to cirrhosis, portal hypertension, hepatocellular carcinoma, and even death. So 75% of people with NASH have type 2 diabetes, 70% are obese. It is the most common non-communicable liver disease at the moment. And interestingly, it's more common in women than men. And there is currently no cure for NASH. So here is what a normal liver looks like. It should be a nice, even gray tone, little black. It represents fluid. So these are the blood vessels inside the liver. Bright white means it's dense. So this is the diaphragm. What we look for is just the evenness of the grayscale from the top to the bottom. So we can see there's no differences in brightness of these echoes. They're all the same brightness. Where here we have a fatty liver. And you can see right away, these echoes are a lot brighter than this liver. And that's because of the fat. You can see that down here, we hardly have any echoes because the fat is very attenuative. It absorbs the sound much quicker than a normal liver will. And actually you can see this diaphragm, we can barely see blood vessels. They're like full of echoes if we can see them. So a fatty liver really changes the architecture of the liver, which in turn gives us the properties we want to try to determine, how severe is this fatty liver. In the old days, we just used to look at it, and I probably would have called this like moderate to severe fatty infiltration. A lot of it depends upon, how far we can see deep in the liver and, how can we see the diaphragm, what do the vessels look like. So the more we lose of that, the more we head towards a severe fatty liver.
So before you, actually, if you could go back, Bob, question sure. I would have, not being an ultrasound expert, is I look at the image on the upper left-hand side and the image on the lower right-hand side, and I can visually see the difference. But you had mentioned you call the one that has fattiness, the lower right, moderate to severe. Based off of what? Just
this was all our old grayscale ways. Before we had elastography, this is the only way we could to do it. So it was subjective to the person reading the ultrasound. We just basically the two things we really looked for was how far could we get to the diaphragm? Because sometimes we would lose the ultrasound beam, say like centimeter or two above the diaphragm and never see it. And then, how well are we seeing vessels inside the liver? Sometimes we don't see anything at all. Here we can sort of see some, but they're going full of artifactual echoes. So this liver is pretty hard to penetrate. So that's sort of what we look at. Again, it was just subjective. That's why we always used to say like moderate to severe, mild to moderate. Most of the time we never said, severe fatty liver unless it was really, the liver looked a lot worse than this did. And then we felt comfortable saying, yeah, that's a severe case of fatty liver. But it was just subjective to the person reading the ultrasound. It was all just based on its look. Great question. And that's why we're so excited about elastography, because now we can be more precise. We don't have to say mild to moderate or moderate to severe. We can look at these values and pinpoint more, where is the stage of liver fatty infiltration? Has it gone into NASH yet? By looking at these numbers. So I think, to me, that's what's exciting. We're able to give our patients or our physicians more information so they can treat their patient better. So again, non-alcoholic fatty liver disease is a very common chronic liver disease worldwide. And the CDC actually states that chronic liver disease and cirrhosis is the 12th leading cause of death. That sort of shocked me that the liver fibrosis was actually responsible for the death of so many people. And it's actually the 4th leading cause of death in a young population, 45 to 65-year-olds. So again, here's the importance of, why we need to diagnose and start treatment, because people are dying of this disease and at a young age.
Yeah.
So fibrosis is a dynamic process. It's not like the fibrosis appears and then stops. It's always growing and getting worse as the patient damages the liver more. And the more fibrosis in the liver, the more stiffer it becomes. So therefore, the sound velocity will be faster through that liver. So as the fibrosis, gets worse and worse in the liver, the sound wave will travel through it faster and faster. Therefore, that's why we have these numbers and these values that we can then say, okay, we're at this stage of liver disease. Eventually, what we'd like to try to avoid is it'll result in portal hypertension.
The portal vein, from what I understand, people do throw color on there, and the gastroenterologist or whatever, they want to look at the portal vein, and there might be some changes in it. Like, what do you actually look for under ultrasound for that?
Well, I got some images coming up, but basically we look at the flow direction. The portal vein and hepatic artery should both be flowing in the same direction, and that is into the liver. With portal hypertension, basically I say the hepatic artery becomes like a bully, so it gets into the liver, can't progress to where it wants to progress, and hits a dead end. So then it can't fight its way upstream through its arterial system. So it's like, here's low pressure, and I can just push my way through the portal vein back into who knows where I'm going to end up. But I got to keep moving. So it pushes the blood out of the liver. So we'll have hepatic arterial blood going into the liver and portal vein blood going out of the liver. And that's real easy to see with ultrasound. Now, I know in the beginning, as I was learning elastography, there was a lot of talk about comparing the liver velocities and putting them into a Medivir score. I sort of think, from what I've been reading lately in lectures I've went to, that I think at least in the ultrasound community, we're sort of shying away from the Medivir score and looking at some other things that we'll talk about. So here's a visual representation. Again, here's nice and normal looking, and then again, the fibrosis starts, it gets worse and worse and worse until we have like cirrhosis in here. So this is all the fibrosis building up. Of course, up to now, the gold standard for determining how stiff the liver was or how damaged it was the liver biopsy. So here we can see actually the needle going into the liver, grab a chunk of liver, pull it out. It's really quite quick, but there's complications. I mean, a lot of these patients, their livers are pretty sick. And as we know, the liver is very responsible for helping the body form blood clots. So if the liver can make its contribution, it can be difficult for the patient to stop bleeding. And they have to wait days for the results. It's not like you get the results instantaneously.
Right.
So even though it's the gold standard, like any gold standard, it has its problems. Not that I think, at least at the moment, liver elastography will become the gold standard, but at least we're comparing it to something we know is not perfect. And it's painful. I do a lot of liver biopsies still, and it's not pleasant. Even though we basically put lidocaine in the skin and we numb the liver capsule as much as we can. And I always tell the patient that's the worst part. That liver capsule seems to be very sensitive. And then we do the biopsy. There's a lot of pressure, and a lot of patients think pressure equals pain. So I try to tell them, no, that's just pressure, which is nothing we can do about. But it still is quite painful to some people. Some people take it very well. Other people, you would think we were killing them as they scream and yell while we're doing this procedure. And typically you like to get at least 2 liver cores, because basically you want to make sure you have enough liver tissue so the patient's not coming back again for another liver biopsy. So there is some pain involved, even though we try to make it as minimal as possible. And of course, the bleeding risk. So, after we pull the needle out from our last biopsy, I will take color Doppler and I'll look in this area and see if there's any blood squirting into that perihepatic space. Fortunately, I've only said it very few times. And those were on patients with really bad cirrhotic livers that were on platelets while we did the procedure. So it was kind of expected on them. Hopefully it wasn't going to happen. So, there's always that chance. And it's painful. These people that have had these post-hepatic biopsies bleed, they're in a whole lot of pain. And I think because it's like irritating that liver capsule.
From what I understand, about 5% of liver biopsy, correct me if I'm wrong, 5% actually turn into, very complicated cases.
I would think that's about right. fortunately, it's not a large percentage, but the more severely the liver is damaged, the higher the chance of a complication occurring. And of course, it's not perfect. There is some sampling errors because this fibrosis is not uniform through that liver. We're just taking a chunk of liver right here, and whatever fibrosis we go through and normal tissue we go through is how they're going to make their decision. So I've seen literature that says, up to 30% of samples result in incorrect staging, either, higher or lower than it should be. And this is why, here's the fibrosis here in this liver sample, all the red's a nice normal liver tissue. But if we took the needle and sort of got our slice of tissue like through this area, there's going to be a whole lot more fibrosis tissue they're going to see than normal tissue, as opposed to if it went like this, we would see much more normal tissue than fibrotic tissue. So this is going to cause it to be a higher value, think that there's a higher degree of fibrosis in this patient than there truly is. And then you got situations like this where the needle just goes through a lot of normal liver tissue and just a small amount of fibrosis. If we had taken it over here, we got a better value. But we're going through like this little bridging aspect, and that's going to say, oh, there's F1 at the most. So there's this is the problems with anything. So with liver biopsies, they're not perfect, and I think sometimes we need to remember that when the ultrasound and the liver biopsy may not correlate pretty well, that maybe it's not the ultrasound, maybe it was the liver biopsy that was overestimating or underestimating the degree of fibrosis. So here's another series of pictures. Another thing we look at with fatty livers is the echoes inside the kidney. Again, here's a nice normal liver. This is what we would call a longitudinal approach. So we're going up and down the body from like head to foot. So here's our liver right here, the right label liver, and here's our right kidney. And the bright white in the middle is the collecting system of the kidney. And this is the brightest echoes we'll see in the abdomen, is that. And the parenchyma of the kidney is actually the least echogenic thing we'll see in the abdomen. So the kidney gives us our least echogenic and our most echogenic. So as we start to get fatty liver, again, we can sort of see that these echoes are getting harder to see. Get a little bit of decrease of penetration here, not really seeing the diaphragm in nice bright white. Where over here, where we have like a severe liver, again, very bright echoes. Look down here, we have no penetration. The sound beam has run out. It almost looks like there's no echoes inside this kidney. So those are the kinds of things we're looking for, that we can still see the vessels pretty well here. So we sort of take a look into here's what normal looks like, and here's what we got, and going to try to determine, what's kind of staging of fatty liver the patient has. And again, it's pretty much subjective. I mean, some people always say this looks more like severe, but if you look at the fact that this liver is absorbing the sound beam much more than this liver, then this is actually at an advanced stage. And maybe we just took a picture and there really wasn't a lot of vessels in this area. So it's just a matter of getting the right image to really do your correlations between, especially like the liver and the kidney. So
you're looking at the brightness of the echoes in addition to what's called the far field, further down the image, to see if there's any low lying or no presence. Yeah. So I mean, look over here. We got, again, the brightness of the echoes are same from anterior to posterior. Got a nice bright diaphragm here, like we expect. Here we're starting to lose things, and here we've lost things. I mean, let's say there was a HCC rate, a small HCC right here. Well, we can't see it because we don't have enough penetration to see that deep in the liver. So then you worry about, well, what am I missing here? And here's a cirrhotic liver. So now we have a really dense liver. We'll see the black is fluid. So this is ascites around these livers. Very, very dense. A lot of times we'll take a
high frequency, usually a linear rate transducer, and look at the capsule, because it should be nice and smooth, but here we can see that it's not, and we can actually see some of these little nodules that are in the liver that we don't really appreciate with our, say, our abdominal transducer. So this would be like something we use on carotids or maybe even thyroids that we're looking at, because it's the higher the frequency, the more detail we get, but we can't penetrate very deep. The lower the frequency, we can penetrate deeper, but we lose some resolution. But I think you can really appreciate all these little nodules we're seeing now. And then here's a severe, the liver's starting to shrink up now. We have a lot of ascites. So those are the kinds of things. You can see this has really got an irregular contour. We can see that without putting the high frequency linear on. And
ascites is fluid, and on ultrasound, fluid shows up as hypoechoic, is called in the sonographer world.
Well, not really. Hypoechoic would be this: the kidney is hypoechoic to the liver. It sort of means less echogenic or less. There are no echoes in fluid, so we would say that is anechoic, without echoes. So black, every time we see black in ultrasound, it equals fluid, because there's nothing inside the fluid to send back echoes.
Okay.
So here we have a nice normal portal vein. Red, it's going, when you look at this, the top color bar is flow towards the transducer, which would be in this case towards the surface. Blue would be flow away from the transducer. So again, we have some nice red flow, which is what we'd like. It's coming from like, mid-gut up to the liver. So that's going towards the surface. And again, a nice sort of waveform here. So let's compare that to some others. So here again is that liver, really nice. Here, again, we got blue. So this is going away from the liver. And we got the red of the hepatic artery right here. So the artery is going into the liver. The portal vein is going out. And here, this patient, we've got taken a Doppler sample and actually caught both the artery and the vein in the same area. So we can actually see the arterial blood going in and the venous portal blood going away from the liver. And you can see it gets a little bit more different waveform to it than we have here in a normal. And then we also will be looking for regenerating nodules. So this causes a lot of problems, as we're going to talk about. So again, here's a lot of ascites. Here's our liver. Now the liver is brighter than it should be, as you remember when we compared it to normal livers. So when the liver is trying to regenerate itself, the normal liver tissue is going to be the echo density that it should be as a normal liver tissue. So it's going to look hypoechoic to the cirrhotic liver tissue. So we'll have these little nodules in here. But the problem is, this is exactly how hepatocytic carcinoma will look. So, there's no way to differentiate between the two unless by biopsy. So here's a patient with HCC. Here's a patient with regenerating nodules. So you can see that they look pretty similar. Look at this one. It's sort of like the borders are a little bit more ragged, and this is a lot more smooth. So I would have thought the other way around, but these were both biopsied, and this was HCC, and this was regenerating nodule. So, that's another problem we face. All right, take a little break here from ultrasound. These are my furry children, our little baby Sammy, our old man Ollie, and my cat Maggie.